having me, Ren. This is a beautiful place, and for those of you that haven't stayed here or been to the bathhouse, I can't recommend it highly enough. It's a magnificent space and it's truly beautiful in the bathhouse as well. So thank you for inviting me. What I wanted to do today was to talk about the principles of the gut-brain axis and how it impacts not just gut health and functional gut symptoms, but also how pivotal it is in overall health. People don't realise that their gut, particularly if it's not causing any overt symptoms, is actually driving a lot of their disease. So I'll give the talk, and then at the end, if there's any questions, I'd like to focus on sort of what you all think is interesting and what you want to know about, and so we can talk about some options and questions then. So to start, the gut-brain axis. So the gut-brain axis I like to think of as the two-way communication between the gut and the brain, and the gut includes the microbiome as well. It allows both of those organs to heavily influence the functioning of the other organ. In order to do that, it has to be linked, and so it's linked by three main systems. There's what we call the HPA axis, which is the hypothalamic pituitary adrenal axis, which is the neuroendocrine or the nerve and hormonal aspect of the gut-brain axis, where the brain tells the adrenal gland to pump out stress hormones, particularly cortisol, and then the implications that has on the body. Then the second arm is the autonomic nervous system, and we all know that there's the fight or flight or the sympathetic nervous system, and then the parasympathetic or the rest and digest. And the parasympathetic arm is mainly made up of the vagus. And what people don't realise is that they're both always on. It's just what you're doing at any one point in time. Are you more in a sympathetic mode or more in a parasympathetic or a vagal mode? But they're always, it's on. It's just there's this fine-tuned balance. And then there's the immune system, and the most important aspect or the area I'm interested in is the mast cells, and I like to think of the mast cells as our danger cells. They protect us from danger. And then there's the gut or the and the microbiome. So this is the diagram that I've designed just to show how the gut-brain axis works and how dysfunction in the gut-brain axis leads to generation of symptoms, not just functional gut symptoms, but pretty much all of your health symptoms. And so when we talk about the microbiome side of it, so if you look on the left side, this is, where is it? No button. So on the left side where it says eubiosis, that's the normal gut. So eubiosis means your collection of bacteria or microorganisms is balanced. There's lots of different types of good bacteria, and the microbiome is incredibly important. It's only just in mainstream medicine everyone's starting to realise how important it is for every single disease. And whilst it has many functions, one of the main functions that I really want to focus on is its role in the gut barrier function. So on the left side, you can see that the lumen of the gut where the faeces lives, nothing can get through into the body unless the body wants it and allows it to be absorbed through the cell. But then on the right side of the bowel, it says dysbiosis. This is where your microbiome has become dysbiotic. The population is skewed. There's not enough good bacteria, not enough good bacterial populations. And one of the most important things that the microbiome does is it actually helps maintain the tight junctions. So they're the little anchors that live, if you can see on the diagram, little anchors between the lining cells of the bowel that hold them together so it forms that impermeable barrier. And when you lose those tight junctions, the cells start to drift apart, and now things can sneak through that the body doesn't necessarily want getting into the body. And so now you're getting toxins, food particles, bacterial products getting through into the body. And obviously that would lead to you being incredibly sick, so the immune system mounts an inflammatory reaction to try and kill these invading toxins and other products, and so that leads to inflammation. But then the immune system, in turn, then signals to the brain that there's danger, and so it then further causes activation of the HPA axis and the sympathetic nervous system. So if you like, the brain says, oh my goodness, we're activating inflammation, we must be in danger because we're protecting ourselves from these toxins, we better go into flight and flight mode. And so then you go around, and so you can see that you just end up going around and around and around, and I call that the merry-go-round. So merry-go-round or dysfunction in the gut-brain axis. So how does it arise? And it arises because of exposure to chronic stress and the accumulation of chronic stressors, if you like. Why is it important? Like, why do we actually care if the gut-brain axis is going round and round instead of just relaxing? And it's important because when the gut-brain axis is chronically activated, it actually puts pressure on the genes that you inherited. So when people get diagnosed with an autoimmune disease, they often say, why did I get it? And it's like, well, we say that a genetically predisposed individual is exposed to a trigger that leads to the development of that disease. And so for type 1 diabetes, we know that rotavirus or COVID is the trigger to act on the genes that predispose you to type 1 diabetes to get type 1 diabetes. But that applies to all disorders. If you have a genetic tendency, that tendency has to be triggered for it to turn into a disease. And so it actually, when the gut-brain axis dysfunctions, it's responsible for the development of neuropsychiatric diseases, so anxiety, depression, ADHD, autism, OCD, eating disorders, Parkinson's, Alzheimer's, multiple sclerosis, autoimmune disorders, all and any autoimmune disorders, allergic disorders, inflammatory disorders, and most common inflammatory disorders I see are acne and endometriosis, and metabolic disorders, so weight loss, weight gain, blood pressure, cholesterol, heart attacks, strokes, diabetes, and then cancer. And so these are what we call disorders of the gut-brain axis. And if you look, they're the disorders of the modern world. I mean, all of these disorders are rising, and everyone's saying, why are they getting worse? And that's because the easiest way to upset your gut-brain axis is to eat a poor diet, not exercise, and be exposed to mental stress, which is what every generation is happening. And so every generation inherits their microbiome from their mother, destroys it with their current lifestyle, passes that altered microbiome onto their children, who further destroy it with their worsened lifestyle. And we're just poisoning ourselves through our gut. I mean, there's lots of other factors, but it's the easiest way to disrupt the gut-brain axis is by causing dysbiosis through our modern lifestyle. So how do we treat dysfunction in the gut-brain axis? It sounds simple, but in practice it's quite difficult. So we remove the stress. But the trouble is you've got to find the stress in order to remove it. So in order to remove the stress, we need to define stress. And this is where most modern medicine gets it wrong. So the definition of stress is any real or perceived danger to an organism. It doesn't have to actually be a real danger. So that's why psychological danger, where you worry about things in the future that haven't actually come to pass, can be a problem. But when we think of nature and animals, when they're exposed to danger, and the analogy I use is running away from a lion, there's two outcomes. The lion catches you, eats you, and you're dead, or you escape, you survive, and you recover. But animals know something that we as humans have forgotten, is that when they're exposed to a danger, they don't just go, oh, thank goodness I escaped that horrible lion, okay, what's for dinner? They actively put into place behaviours that stimulate their vagal tone. So they shake, they shiver, they go into a state, or they'll do breathing, and they withdraw themselves from a sympathetic state and go into a state of vagal tone, so they balance it out, and so they recover from the stress. We as humans don't do that. You get exposed to the stress and you just march on with your next day. And so in humans, there's a third option, which is where the lion chases you every day for 17 years and doesn't catch you, and that's chronic stress. And this involves what we call the concept of allostatic load. And so when you get chronic stresses that you don't effectively deal with, and so they remain a stress in the body, and then you add another one to it, and then you add another one to it, until the straw that breaks the camel's back, and now you're unwell. And this is a difficult concept for patients. So I sort of draw a line and I say, okay, down the bottom, you're completely healthy and you have no symptoms. And then you decide to go and get some breast implants, which we know are not very good for people predisposed to Mast Cell Activation Syndrome, because their mast cells don't like the shear forces of the implants. So you start to activate your gut-brain axis, but not enough to get any symptoms. And then you start to have some allergies in life, then life throws some tricky things at you, then you live in a mouldy environment in Queensland, then you become fecally loaded and don't realise it, and then COVID is the straw that pushes you over the edge, and now you present with long COVID. I can't take COVID out of the body, but I can take those other ones out of the body. So I don't care which one I remove or which order I remove them in. I've just got to remove enough of the stresses to get you ideally back to that low line, but get you below the threshold of symptoms and diseases so that you feel better. And so a lot of people will say, I'll say to them, look, I can't get you better. I suggest having your breast implants. Oh, but I've had them for years, that they haven't been causing a problem. It's like, no, but they're adding to the problem. And I can remove fecal loading. I can't remove COVID. I can't remove life stresses. That's the way that you live your life, and it's a decision you have to make. But I can do the fecal loading, the mould, and the allergies and the implants. And so for every person, they have a different graph that looks like this, and different sizes of the arrows contributing. But the theory is just to get you below that threshold of disease generation. So the definition of stress is where modern medicine gets it wrong. So particularly with irritable bowel syndrome or functional gut symptoms, which are predominantly a female disease, when most doctors think of the word stress, they see a woman, they go, oh, you're anxious. That's what your problem is. You need to go and relax and meditate and hypnotherapy, and they're fantastic things, but only if mental stress is one of your stresses. It's not a stress for everyone. So you could have a hectic life and it may not be impacting you, just like some people can be exposed to house dust mites, and that's fine, they're not allergic to them, so it doesn't matter if there's dust mites in their bed, whereas other people that are allergic to them, it's a stressor. And so I don't like to use the word stress, so I replace it with danger, because then, you know, it's easier to remove the danger rather than think about the word stress. And I view danger as coming from the outside world or from the inside world. And most of our danger actually comes from the outside world. And again, this is where people underestimate the gut. So here's some fun facts about the gut. So it has the largest surface area of any organ exposed to the outside world. So you've got the gut lumen where the feces live. And where the feces live is actually outside your body. It just happens to be inside your body. And I use my donut analogy, where if you've got a donut, the whole of the donut is not part of the donut. It's inside the donut, but it's actually outside the donut. And then you put lots of donuts together and you get a tunnel. And so the whole now becomes a tunnel, which is your bowel, and what's in the tunnel is outside your body. So it's also the largest endocrine or hormone-producing organ in the body, and it makes over 30 different hormones. It's the largest immune organ in the body. So 70% of all of the immune cells in your body reside in your gut. It has the largest collection of nerves outside of the brain, and so the enteric nervous system is the gut's own nervous system, and it's sometimes called the second brain. It can work independently of the autonomic nervous system. It's the third branch of the autonomic. There's the sympathetic, parasympathetic and enteric. But for the fine-tuning purposes, it does need the input from the autonomic nervous system in the brain. It has the most complex and diverse microbiome, and everyone's been focusing on the gut microbiome, but there are multiple microbiomes throughout the body. There's our skin microbiome, there's our respiratory microbiome, there's our mouth microbiome, there's our vaginal microbiome, and there's so much evidence coming out each week on the importance of disruptions in those microbiomes to diseases. It's just that we focus on the gut because it's the biggest microbiome. And so when you put it together, it has the ability to be the largest threat detection network in the body. And so it's uniquely positioned to be exposed to danger and respond to danger. So I say to my patients, if danger comes from the inside and the outside world, then the gut has the largest surface area and threat detection network. So biggest bang for buck for your health is to fix your gut. And if you fix your gut, it's going to improve so much with such a little input, as opposed to focusing on other things that might be contributing that much. So I want to come to the concept of fecal loading. As gastroenterologists, we're not taught a lot about functional gut disorders. So irritable bowel got renamed functional gut disorders, and then they realised that functional assumed you were psychologically worried. So they changed it to disorders of the gut-brain interaction, which is a lovely fancy word, but it still doesn't tell us why we get symptoms of irritable bowel. And everyone goes, you've just got DGBI, off you go and do your psychological treatment. And so fecal loading is extremely underappreciated as a cause of symptoms. And so constipation is actually a symptom. It's what the patient describes you, and it's either the passage of a hard motion or you don't go to the toilet very often. Defecatory dysfunction is, again, a symptom, and it's difficulty evacuating a motion regardless of whether the motion is hard, soft or loose. So it's an outlet or a muscle or a sphincter problem. And it's more obvious when the motion is hard, whereas the motion's liquid, it just comes out easily. Whereas fecal loading is a finding. It's something that your doctor realises is going on, and it's the presence of hard faeces in the colon. And so on the right is a graph, and this is the Bristol stool chart that I use to explain it, because I can have patients say, I'm constipated, and they're doing a number 4, which is beautiful, but they can't get it out. And that's not constipation. They have a problem with the defecatory technique. And so it's really important when a patient says they're constipated to actually realise what they mean and how bad. Are we talking, I pass a type 3 every day, or I pass pebbles once a month? And nobody talks about it. If you ask a gastroenterologist, you put 100 gastroenterologists in a room and you say, what's a normal bowel habit? You'll get 100 different answers. I used to say, I don't care how often you go, as long as you have no symptoms, it doesn't hurt, and you feel fine. But I've now revised that, because you can have fecal loading, and we'll see why that's a problem in a minute, with no gut symptoms, and it's still an issue. So now I say, I don't want you to be fecally loaded, and they all look at me and say, well, how do we decide that? And the worst part is the people that have a normal bowel habit. So I think normal is a type 4, and I believe that you should be passing a type 4 motion on a daily basis, and a decent size, not, this much. So how does fecal loading arise? So I say to my patients, okay, you see a line and the sympathetic nervous system gets activated. The sympathetic nervous system's main role is control of blood flow. And so what it does is, when you're faced with an acute dangerous situation, it gets activated and it rediverts blood flow from the non-essential organs to the essential organs. You don't need your gut to run away from a lion. If you stop to have something to eat or you stop to go to the toilet, the lion eats you. So your gut shuts down. Your sphincters all contract, your colon slows down, your small bowel slows down, your upper gut slows down, and it causes irritable bowel. It's not. You're in a state of fight or flight, but you're only supposed to be in a state of fight or flight for the 5 minutes it takes to run away from the lion, and then you're supposed to go back into rest and digest. But my patients are always in a state of fight or flight. And so feces enter on the right side, so on the left side of the diagram, on the right side of the colon in liquid form from the small bowel. And the large bowel's job is to move the feces around whilst at the same time reabsorbing the fluid, so that by the time it gets down to this squiggly bit at the bottom, the sigmoid colon, it should be that beautiful number 4. But now the colon is, you're running away from a lion, the colon is shut down, but the water is being reabsorbed still. And so the motion is getting harder and harder and harder. You're supposed to have feces in the bowel, but it's not supposed to be hard. And this is where the problem arises. So what happens is the cells, hang on, so where am I going to come to that? Okay, so we'll come to that in a minute. So fecal loading is really important because it's caused by the initial dysfunction in the gut-brain axis, but then it perpetuates the dysfunction in the gut-brain axis, because when feces is hard, it activates the, we'll go back to this diagram. So if you look on the side, it says there's the enterochromatin cells, which are the ones with a squiggle, and they are really important cells. They make 95% of the body's serotonin. So they're very, very important, and they're unique in that they have what we call mechanical receptors or mechanoreceptors on them. So the hard feces pushes on the pressure receptor on the EC cells and triggers it to release serotonin. And then serotonin causes the mast cells, because they have receptors for serotonin, to think there's danger. So the mast cells go, oh, there's danger. They open up, they attack the dangerous poo, but in doing so, they accidentally destroy the gut lining with inflammation. Plus, you've got this stagnant feces there, which allows overgrowth of bad bacteria. And it's not always SIBO, sometimes it's large bowel overgrowth. And so you get overgrowth of the bad bacteria, and then you get dysbiosis, and that causes the leaky gut. And so all of these factors contribute to leaky gut and then cause that perpetuation of the cycle. But it also is the cause of the most of the functional gut symptoms. Not all of them, but most of them. And the tricky part is that fecal loading can present with no gut symptoms. It can present with colonic symptoms, and it can present with just constipation, alternating constipation and diarrhea, bloating, pain. It can present with just upper gastrointestinal symptoms, and it can present with a mixture. But if somebody comes in and they say, oh, I've got this terrible, horrible, painful diarrhea every day of my life, I'm going 5 times a day, and I go, here's some laxatives, off you go. They walk out and go, she's a little bit strange. I came in with diarrhea and she gave me laxatives. The reason it causes the diarrhea is because of the diverse functions of serotonin in the gut. So this is your enterochromaffin cell, and when serotonin is released, so the lining cell, the enterocyte, the serotonin tells the lining cell of the gut to make water and mucus, water and electrolytes, and put them into the bowel, into the lumen. The goblet cells, it tells them to make mucus. And so mucus is designed not just to protect the gut barrier function, but mucus is also produced to help lubricate the feces and help the feces come out of the bowel. And then it acts on the mast cells to cause them to degranulate and release pro-inflammatory mediators. It has multiple other, in fact, actions. And then it acts on all the different types of nerves. When it actually acts on the vagal reflexes, what happens is the serotonin activates the vagal reflex, goes up to the brain, comes back, and it actually slows upper gut emptying, because the colon says to the stomach, we're so full of poo down here, there is no more room, so please stop sending more stuff down. So you lose your appetite. You feel full when you eat a small amount. You feel nauseous all the time. You very rarely vomit. You might bloat. And if the acid doesn't stay down and you've got a lax GI junction, the acid will come up into your esophagus and mimic reflux. And so the most common cause of upper gut symptoms when you have these kids that are just nauseous all the time is actually their bowel habit. But if you say to them, what are your bowels like? Oh, fine. What's fine mean? Oh, I pass pebbles once a week. No. Just because it's not bothering you doesn't mean it's not causing your symptoms. So you always start your history at the bottom of the gut, because it's a tube. If you can't keep sticking stuff in the top, if it's not coming out the bottom, it's just going to fill up. So you have to find out what their bowel habit is, not just, I'm happy with my bowel habit. What does it look like? And nobody talks about poo because it's disgusting. So we don't sit around the dinner table saying, did everyone do a poo this morning? Can they tell me what it looks like? My kids think I'm weird. Mum, it's disgusting. Stop asking me about my poo. But, you know, passing a type 3 motion twice a week is not normal. But nobody talks about it, so no one knows what's normal. And even gastroenterologists can't agree on what's normal. So, oops, where are we up to? Okay, so what you can see is that the fecal loading causes diarrhea because the serotonin is released, and it causes irritation of the gut, it causes pain, it causes the gut to move faster, and it throws in water and mucus. And so a hard motion comes out as pain, urgency, out comes diarrhea. Or once it's all emptied and that hard motion's moved away from those echinoreceptors, and then the patient relaxes and goes, oh, that horrible pain's gone away, until it builds up again. And for some people, they might build up every 3 months and have an attack where they have normal bowels they're happy with, and then suddenly they have this attack of pain, urgency and diarrhea, and then not again for 3 months. Some people it might happen once a week. Some people are going to the toilet and having 20 painful small motions a day because they're so full of poo. And the more diarrhea you have, and the more pain you have, the worse the fecal loading is. But then in other people, they can be severely fecally loaded and not have any symptoms. And it's very complicated. I haven't figured it all out, but it's to do with your serotonin receptors, your density, all of those things. It's so complicated. But everyone has a different way that they present. But most people, I have people that have had diarrhea for 20 years and they've been put on gastrostop and loperamide and all of these things to slow down their gut. And I say, no, you're full of poo. And they look at me, and then sometimes it can take me 12 to 18 months to get that poo out. I've now got a system that's a lot quicker, but it can take a long time because you've not only got to get it out, you've got to stop it recurring in the first place. And a lot of people say, but I'll end up addicted to my laxatives. And it's like, I don't know where that came from. You're constipated because we're not addressing why you're constipated. So laxatives are a treatment for your constipation. If you stop the treatment, you go back to being constipated because we haven't addressed the underlying issue. And I say to my patients, well, are you addicted to your high blood pressure tablets? You take a high blood pressure tablet to reduce your blood pressure, but because you're overweight and you don't exercise and you have a terrible diet and you're stressed, as soon as we stop the blood pressure tablets, your blood pressure goes back up again. You wouldn't say you're addicted to your high blood pressure tablets. So I say it's actually better to take laxatives every day than to be full of poo and have your gut-brain axis activated and driving the disease pathogenesis of all your other diseases. So what I wanted to talk a little bit about is, you've probably all heard of POTS and MCAS. And so POTS is what we call Postural Orthostatic Tachycardia Syndrome. MCAS is Mast Cell Activation Syndrome. And when you've got that gut-brain axis going round and round, when you're chronically in a state of fight or flight all the time, that's what I call POTS. It's where you're always in a state of fight or flight. And POTS can be subdivided into a hyperadrenergic, too much adrenaline. But these patients, every time they stand up, they release too much noradrenaline. And so every time they stand up, they've got noradrenaline flooding their body. Not only does that shut their gut down, it gives them palpitations, it makes them sweat, has all these weird symptoms that people mistake for anxiety. And it's like anxiety starts in the brain and your body reacts. Adrenaline makes your body react, and then your brain questions why. If you don't say, why is my heart rate going 150, there's actually something wrong with you. So it's appropriate. So a lot of patients get dismissed as having anxiety. They can have anxiety as a comorbidity, but one starts in the brain, one starts in the body. So, and then when the immune system, so when the gut-brain axis goes round and round and the immune system is chronically activated, as a simplification, that's what I say Mast Cell Activation Syndrome is. And I don't believe that you can have POTS without MCAS. And that's because the gut-brain axis goes round and round, but it works as a team. So the sympathetic nervous system or the autonomic nervous system and the immune system have communication. So when you look at the mast cells in the gut, I think 70% of them live within 2 microns of a nerve ending. And we used to think that nerve endings could only innervate stationary organs, but we now realise that nerve endings can innervate cells. So the nerve endings talk to the mast cells and they talk to relay signals back and forth from the brain. So if the sympathetic nervous system is detecting danger, it's going to tell the mast cells, oh my goodness, there's danger. I'm going to get us out of here. You go and kill the danger while I run away. But if the mast cells see the danger first, they're going to say, oh, there's danger, I'm going to kill it. And then they say to the autonomic nerves, get us out of here, it's dangerous. And so if they're a partner, if one's hyperactive, the other one's going to be hyperactive. So whatever makes one worse will make the other one worse. But conversely, whatever makes one better will make the other one better. So you can spiral down, but you can spiral back up again. So it doesn't matter what you treat, the other one will get better. And so people think that these disorders are rare, but they're not. They're highly misunderstood and often dismissed as anxiety and something that only happens to teenage girls and that they'll grow out of it. I routinely do a NASA lean test, which is the test to diagnose POTS. It's what we call the poor man's tilt table test. NASA, space agency, you lean against a wall, you follow the instructions, and pretty much, and I usually do it 3 times, and everyone has POTS, or they have the tendency to POTS, and it's like if I text enough times, I'd find it, but I don't persevere if it's not bothering them, because irritable bowel or functional gut symptoms are disorders of the gut-brain interaction, but we don't stop to think what that means. It's because the HPA axis is dysregulated, the autonomic nervous system is dysregulated, and the immune system is dysregulated. So I view irritable bowel or functional gut symptoms as the gastrointestinal manifestation of POTS, MCAS, and HPA axis activation. But the POTS causes the vast majority of the symptoms. Then the mast cells, the HPA axis contributes but doesn't cause a lot of this. Well, it reacts, but it's not a lot of the symptoms. And then I don't know if you've heard of the trifecta syndrome with hypermobile EDS. So when you have chronic activation, the HPA axis, the autonomic nervous system and the immune system control the laxity of your connective tissue. So if they're all overactive, your connective tissue is going to get looser. And I've seen people go from being not meeting criteria for hypermobile Ehlers-Danlos loss and becoming more flexible and watching their connective tissue degrade in front of my eyes. And then if you're born with hypermobile EDS, and I view that as the only form of EDS that's, I don't think it's genetic, I think it's polygenic with genetic influence, with environmental influences, then your gut-brain axis just needs one little insult to push it over the edge, so you're more susceptible. So when we look at the autonomic nervous system, so again, it's supposed to balance and it gets stuck in fight or flight, and it causes so many symptoms because the autonomic nervous system controls all your automatic functions. It's controlling your heart, your respiratory system, your gut, your genitourinary system, your temperature control, your blood sugar control, and it makes you exhausted, you don't perfuse your brain. It causes all these symptoms, but when somebody comes in complaining of all of these things, there's no way we can put it all together because we're all trained to subspecialise. We're not trained to look at the big picture. And POTS is a neurological disease, but it very rarely causes neurological symptoms. So the neurologists see it, the cardiologists see it, and they just want to control the heart rate, not realising it's causing the tiredness. And so I ask my patients all of these symptoms, and they always tick all of these symptoms. And then the mast cells, or MCAS. So MCAS in a nutshell, the mast cells are our danger cells, and they protect us from danger. So when you have an anaphylactic reaction, say to a peanut, your body's allergic to a peanut, you eat it, the mast cells say, oh my goodness, there's this very dangerous peanut, I've got to protect this person from a peanut. And so they throw all their chemicals at the peanut, they kill the peanut, but they also almost kill you by making this nasty anaphylactic reaction. And they have over 300 receptors on their cells, and some of those receptors will stabilise the mast cells and make them less likely to attack things, and some of those will cause the mast cells to activate and attack things. And what we don't know, because this disease is in its infancy and no one really believes in it, is that not everyone, so this receptor on you might be what's causing all of your symptoms, but in the other person, that receptor is not involved in their symptoms. And it's just like each stress activates the mast cells through a different receptor. And so I know that if you have post-infectious IBS, it's usually a bacterial infection. Bacterial infections activate mast cells through something like toll-like 4 receptor. Low-dose naltrexone inhibits that interaction. So technically low-dose naltrexone should be a good treatment option for you. And so when we have that stress receptor symptom correlation sorted out, we'll be able to address this disease much better. But at the moment, it's just hit and miss, and it's like, let's try this drug and this drug and then this drug, and we just work our way through because we don't understand enough of it. And when you talk about long COVID, so this is how I got into this area, is that long COVID in 80% of cases is where people present with chronic fatigue-like symptoms. And it's because COVID is the stress that triggers POTS and MCAS. So most of my patients with long COVID, they have the unique problems of COVID itself, which is a viral infection that persists in the body, that's separate. But then the COVID triggered the POTS and the MCAS, and that's causing the vast majority of the symptoms. So if I control the POTS and the MCAS, they'll get better. Then you can focus on the fact that the virus is still lingering in the body and what that's doing. And so that's why it's becoming more common. And some important receptors to take note of, particularly as this room's predominantly female, one is histamine. So mast cells are activated by histamine, but they also release histamine and then reactivate themselves, which is a double-edged sword. It's like CRH. So CRH is the start of the HPA axis. You get stressed, you release CRH. Mast cells are activated by CRH, which is how mental stress can cause physical symptoms. You become acutely mentally stressed, your mast cells get activated and cause symptoms. But then mast cells release CRH. So it becomes a vicious cycle to activate more. And so it never made sense to me. When you're chronically stressed and running away from a line, you're constipated. But why is it when people get acutely stressed or they have an exam or they run to the toilet and have diarrhea? And so I sort of view it as, well, when you're chronically stressed, the gut slows down to redivert energy to the essential organs. But when you're acutely stressed, the mast cells are trying to purge and kill the danger. And if they think it's in the gut, they're going to try and purge the danger and flush it out of the gut. And so they cause diarrhea. And you can have acute on chronic stress as well. The other ones are your female hormones. And so estrogen activates mast cells and progesterone stabilises mast cells. And this is why when you look at irritable bowel, so whenever a patient comes into me with a new disease or with irritable bowel, I look back in the last 6 to 12 months of their life and I say, what happened in the last 6 to 12 months of your life to trigger this disease? Because there's always a trigger or a stress. Sometimes it's so many, they're all adding up and you can't pick it. But others are like, oh, yeah, went to Thailand and got food poisoning and I've never been the same since. Or I got glandular fever, or I got COVID, or I had a car accident and had a neck injury, or, granny died, parents got divorced, and so there's always a reason, and so you need to look for it. Most people with irritable bowel, the majority of people with irritable bowel, their first symptoms begin usually within a year of puberty. So for girls, within a year of getting their period, because the stress of going through puberty triggers their gut-brain axis. And so that's why when we look at women, any time of major hormonal transition, so pregnancy in the postpartum period, perimenopause, but sometimes just the cycling of the hormones in their menstrual cycle is enough of a stress to their body to cause symptoms. And so I have, not all, but a lot of my patients actually have worsening of their symptoms with their menstrual cycle. And so if you say that, to me, it means you've got MCAS until proven otherwise, because what else causes it? So this is your normal menstrual cycle. So day one is the day of your first, was when you start to bleed. And then that's the follicular phase. And during the follicular phase, the estrogen starts to rise. It peaks when you ovulate. And then when you ovulate, you release an egg, and the follicle leads to something called the corpus luteum. And the corpus luteum pumps out progesterone. And so after ovulation, your progesterone progressively rises whilst your estrogen drops. And then it all drops, and then you have the withdrawal bleed or your period, and then we start again. And so most of my patients, when they say my gut, they'll say that in the 2 to 3 days before their period, they become constipated. And then when their period begins, for the first 2 to 3 days of their period, they get diarrhea. And that is, you look at the hormones and it makes sense, because progesterone slows down or relaxes smooth muscle. So just prior to your period, your bowels are going to be more relaxed. They're not going to move as much. You're going to become constipated. Plus, if your bowel habit is perfect, so you do a beautiful Bristol type 4, it might be because you have a little bit of constipation and a little bit of diarrhea, but they cancel each other out and you're normal. So when you then stabilise the mast cells are causing the diarrhea component of your bowel. And so when you stabilise them, you take away that diarrhea component of your bowel habit and you become more constipated. And then when the estrogen starts to rise and the progesterone drops, the mast cells become more active and then they cause the diarrhea. And so when you go through perimenopause, obviously when you start to go through menopause, you run out of eggs. And so and then your cycles become irregular, because some cycles you release an egg, and that cycle is your regular cycle. And then other cycles you don't release an egg because you're running out. And so that one, when you don't release the egg, you don't make the corpus luteum, you don't make your progesterone, you don't stabilise your mast cells. So in the cycles where you don't release an egg, when you're going through perimenopause, your MCAS symptoms are going to be worse because you don't have that progesterone stabilising effect. And then there's the whole thing of hormones on your brain. So coming back to the gut. So we've said that the gut's the most important part of the gut-brain axis because of its surface area and its unique role as a threat detection system. So what's in the gut that can be dangerous? Well, what's in the gut? There's faeces, there's angry mast cells, there's food that you're eating that you don't realise you're allergic to because we can't test for the allergies, and then there's your microbiome and a dysbiotic microbiome. And the most important thing is the feces. And so if you get the fecal loading out, the dysbiosis is going to improve. The mast cells are going to be less angry because the serotonin's not making them angry. And they will also stop attacking so much the foods that you're allergic to and don't know you're allergic to. So I have people that come in and are having recurrent anaphylactic reactions from the MCAS and they're using 3 EpiPens a week. I get their fecal loading out and their anaphylaxis reactions drop. Who would ever think that laxatives are a treatment for anaphylaxis? And this is the problem with the diagnostic criteria for MCAS, because there's 2 types of criteria for MCAS. But one of the criteria is your response to mast cell stabilising treatment. So if you think you've got MCAS and I give you an antihistamine, because mast cells make histamine, and block that and you get better, okay, that's MCAS. If I give you a drug that stabilises the mast cells and stops them opening up in the first place, then that's a treatment. But if you remove the fecal loading, then the mast cells are no longer being activated. They chill out. Your MCAS gets better, but we don't review that as a treatment for MCAS. And so we'd say, your symptoms got better with laxatives, you don't have MCAS. It's like, no, you do. It's the way we're thinking about it that's all wrong. So fecal loading is the most dangerous because it's underappreciated or completely ignored or gotten wrong. You've got diarrhoea, not that you're fecally loaded. And fecal loading begets fecal loading. So if not treated, it will continue to drive the dysfunction in the gut-brain axis. It will continue to activate the mast cells. And then the mast cells talk to the autonomic nervous system and it worsens the hyperadrenergic POTS. It worsens the dysbiosis. If you then are nauseous and you can't eat and you can't drink, then your microbiome is going to worsen, because in order to keep your bacteria happy, we need 30 different plant species in our diet in a week. We need, a variety. We want, fermented foods, probiotics. We need fibre, all of these things. They're going to make your symptoms worse when you're fecally loaded. And if you're so nauseous you can't even drink, it's the POTS that's causing the slowing of the gut, that's causing the fecal loading in the first place. People with POTS need the basic treatment is 2 to 3 litres of water a day and 10 grams of salt. If you're drinking 500 mils of water a day and no salt, one, you're not treating your POTS, so the POTS is going to make your bowel slow down and going to make your fecal loading worse, which is not stopping you from drinking in the first place. But the POTS, you're dehydrated, you're not treating it, so it's going to suck more water out of the colon to try and replace the blood volume. So it's going to exacerbate the fecal loading. And then we usually start with osmotic laxatives, nice gentle laxatives that work by drawing water from the blood into the bowel. But if you've got POTS, the laxatives pull the water back, and then the POTS says, blood vessels are more important, and it pulls it back. And so there's this tug of war. And so some people find that they don't work, or one day they drink 3 litres of water and 10 grams of salt and the laxatives work, and the next day they're busy and they drink 1 litre of water and 2 grams of salt, and the laxatives aren't as effective on those days. And so I say to patients, it's better to aim for a realistic, consistent target than massively getting you 2 to 3 litres and 10 grams one day and getting nothing the next day, because then it's easier for me to figure out why you're not responding to the laxatives without having to take into account your salt and water intake. And we also know that if you look at mice and you acutely water deprive them, so if you cut their water intake by 50% of their normal, it doubles the colonic transit time. It changes the microbiome and it changes the immune system in the gut. And so it worsens your dysbiosis, it worsens your fecal loading, and it worsens the leaky gut just from reducing water intake. And so most of my patients they need the 2 to 3 litres. They struggle to get that, but then they struggle to even get any in because of their gut symptoms. And then when you're nauseous all the time, or a lot of my patients are neurodivergent, autistic, ADHD, they have extremely limited things they like to eat. So they just eat chicken nuggets and bread and carbs and nothing else. And so the variety of the food they're eating is not sufficient to support a healthy microbiome. And that's either because they feel sick or because of the comorbidities that go along, such as autism and ADHD where they crave carbs. And that's why I don't like elimination diets. I have a lot of patients that will come in that will say, oh, I saw someone and they recommended I do an elimination diet to see. And so I cut out this. And when you cut out a large food group, you're restricting your variety in your diet, you're worsening your microbiome, your dysbiosis, you're worsening it, your gut symptoms get worse. Oh, it wasn't that one. Okay, let's try cutting out this one. And they just keep cutting things out, and their HbA axis gets more dysregulated, they get more fecally loaded, and then they go, this is not working, I've gotten worse, okay, I'm going to go back to eating normally. But now they're so fecally loaded that when they try to eat, they react to everything because their gut is so sensitive, and then they cut them out. They tolerated them before, cut them out, and I have people that come in that are on 3, white potato with no skin, poached chicken breasts, and, lettuce or eggs, and they can only eat 3 things. If I get the poo out, then they'll start to be able to introduce those foods. So the only diets I ever recommend are dairy-free and wheat-free, and I liken it to eosinophilic esophagitis. So I view eosinophilic esophagitis, which is where it's a food allergy, where the cells in your gut, in your esophagus, get angry from the food, and they cause problems, and they cause inflammation, and they make your esophagus stiff, so the food sticks when you come down. I can give you drugs, you can eat what you want, but if your esophagus is allergic to the food, your whole body's going to be allergic to the food. So I can treat your esophagus, but do you really want to eat a food that's poisoning the rest of your body? And when we do the 6-food elimination diet, I don't do that. I start with a 2-food, because dairy and wheat account for 80% of those food allergies. And then there's soy, fish, nuts, and I always forget the last one. So if you look at it, so I do it, and these allergies are not IgE mediated allergies. So IgE, like a peanut allergy, if I'm allergic to peanuts and I stick a little skin prick in my arm, I'll swell up. And that's because IgE mediated allergies turn up under the skin. But these are non-IgE, meaning they're activating the mast cells, but not through IgE. But if your mast cells open up and you have an anaphylactic reaction, do you really care if it's IgE mediated or not IgE mediated? No. But for the purposes of allergy, we have to say it's IgE mediated. So we can't test for dairy and wheat allergies, so we call them intolerances. But why is the esophagus allergic to those foods in people with EOE and the rest of the gut's not? And my view is that in the rest of the gut, they mount a mast cell response, whereas in the esophagus, they mount an eosinophil and a mast cell response. And when we look under the microscope, we can see eosinophils really easily. But if we want to see the mast cells, we have to do a special stain that takes longer and is more expensive, so we don't do it. But I won't do the diet until the fecal loading is removed, because if you picture, okay, we're looking at the danger that's coming from the gut, and if we do it into percentage, 100% of the danger that's coming from the gut, 90% is going to be the fecal loading. So if I leave your fecal loading and say 2% is the dairy, and I say take the dairy out of your diet and we don't address the fecal loading, you get a 2% improvement in your symptoms. You don't notice it. You go, it doesn't work. But now I remove the fecal loading, you've 90% improved. Now you've got 10% of danger left in your body. And two of that, which now becomes 20%, is the dairy. So now when I remove the dairy from your diet, you get a 20% improvement. You go, wow, I'm allergic to dairy. And also you can have previously tolerated these foods until your MCAS is triggered, and now you're allergic to it. So if you've done a dairy-free diet 20 years ago when your irritable bowel was minor and really mild, but now your dysfunction of your gut-brain axis is massive and you are allergic to dairy, it's like if you did it a long time ago and it didn't work, then I'd like you to try it again. And a lot of people don't want to do diet, but I say bear with me and I'd like to do it again. And I have some patients that they go off dairy or wheat and all of their symptoms disappear. They no longer need laxatives. They need nothing. And so I think it is worth a trial, because there are those people that have miraculous improvements. And so I tend to think, dairy, if someone has acne, those little or whatever it is on, hay fever or arthritis, then I avoid dairy. And I've seen people with seronegative rheumatoid arthritis that are on methotrexate and hydroxychloroquine, and they go dairy-free, and then it was dairy-mediated inflammation in their joints, and then they can stop their methotrexate and their hydroxychloroquine, and their seronegative rheumatoid arthritis goes into remission. So I think it is important, but I only ever do dairy and wheat, and then I refer to a dietitian who's much smarter with diet than me to go through the other ones. But you also have to realise that, particularly with kids, diets are extremely difficult, and you do have to be realistic. And I can tell you what to do, but if you're not going to do it because you're 15 and you want to go out and eat McDonald's all the time with your mates, then there are other options up my sleeve. But when you get older and you realise that your health is more important than eating McDonald's, then you might come around to it. But that's the way I view it. So I don't like a lot of diets. And things like low FODMAPs, they're good temporarily, but the problem is people go on these diets for years and you then worsen your microbiome. They're a short-term fix. Remove the substances that are annoying your bowel while I fix your bowel, then you won't be annoyed by those substances anymore. And so I see a lot of people that have been on low FODMAPs. Same with SIBO. SIBO is secondary to something. It just doesn't magically happen. And so, you can have a blind loop through surgery, or you can have lots of diverticular in your small bowel with overgrowth in those pockets. But the most common cause of SIBO is small intestinal bacterial overgrowth, is that the colon is so chock full of poo that there's overgrowth in the colon. And if you overgrow methane organisms in the colon, it makes you more constipated. Or it pushes those bugs back into the small bowel through an incompetent ileocecal valve, and you get SIBO. So I don't test for SIBO and I don't diagnose SIBO because I always remove the fecal loading, and then the bloating and diarrhea goes away. Should I be mopping it up once I've treated it with rifaximin? I don't know. But I see so many people that go, when I'm on my highly restricted SIBO diet and when I'm on antibiotics, I feel amazing. But as soon as I stop them, my symptoms come back. And it's like, that's because it's a symptom of a disease. It's like iron deficiency is a symptom. It's not a diagnosis. And SIBO is always secondary to something. So if you don't fix the underlying cause, of course it's going to come back as soon as you stop the treatment. So in order to treat fecal loading, you need three things to work. You need a rectum that fills the feces and then will open up and evacuate completely. Most of my patients have what we call dysynergic defecation, which is where as they go to push, they have two sphincters, and the external sphincter is under your control. And so when you feel the feces in your rectum, one, you shouldn't have to push. Your bottom should do the emptying all on its own, but sometimes you might need to give a little push at the beginning just to do it. But when you push, you're supposed to relax and open your sphincter so that the poo can come out. My patients push and squeeze it tighter. And so they push a little bit of poo out and they snap the rest off and leave it inside their bottom. Your rectum is supposed to be empty in between bowel motions. And so if there's always a little bit of feces in there, the rectum then goes, oh, that must be normal. I'm going to ignore it. And a little bit more. And then eventually you need to shove a football up their bottom before they'll get the urge to defecate. And this is the problem. And then if you've got connective tissue laxity, because you've got hypermobile Ehlers-Danlos, or what's going to happen is it's going to start to bulge into your vagina, and you're going to end up with a rectocele, or you're going to have a prolapse, and all of these problems. And this is the problem with the autistic and ADHD children, because we don't manage constipation properly. We just give them laxatives and we don't address the fact that they're not pooing. And so they end up with these mega rectums by the time I see them as teenagers, and I can't unstretch your rectum. And so if we don't do pelvic floor physiotherapy and adequately treat this in these young children, we're going to have a generation of adults with colectomies not because their colon doesn't work, because their anus won't open. So you can't get your poo out if the anus won't open. So it's very important, and I recommend everyone that has irritable bowel goes and sees a pelvic floor physio. And if the pelvic floor physio says, yep, you're doing a great job, fantastic. But if you're not doing a great job, then do it. And people can be hypermobile but have a hypertonic pelvic floor. And so that's why irritable bowel goes along with urinary problems and vaginismus and sexual dysfunction as well, because it's a sling. And, you know, in order to defecate, urinate and have sex properly, you need that sling to relax and work. Then you need a colon that can move the faeces through. And so I have a lot of patients with floppy colons. You know, I've got the long redundant colon, and the gastroenterologist was horrified at how hard my colonoscopy was. And they've just got this stretched floppy colon that doesn't move. So I have a very low threshold for precalopride, which is it stimulates the serotonin receptors and it actually makes the gut just contract. It doesn't irritate the gut and make it spit the faeces out. It just stimulates contractility. And then you need faeces that are soft enough to be moved, because if you've got a piece of cement in your colon, it doesn't matter how strong your bowel is contracting, that cement's not going to move. So that faeces has to be rehydrated. So I use osmotic, adequate salt and water so that you're not stealing it from your blood. Your blood vessels are happy, and then the extra water can actually sit in the gut and rehydrate the faeces. And then we use osmotic laxatives to pull the water into the bowel to make them soft. But in some patients, that's not enough, because these faeces have been there for a long time. And so sometimes it's not enough. So colonic irrigation, where you rehydrate the colon, you know, you pop water up the bottom and it soaks the colon, the faeces for 45 minutes. And so the faeces turns, plus it sucks it out, but the faeces will go from being concrete to a soft motion that then the bowel is capable. But now I resort to IV fluid. So in my first visit, I give my patients my osmotic laxative, diagnose their POTS and say drink salt and water if you can. Then I add in the next visit precalopride if they're still constipated to stimulate it. And I said the precalopride works. If it doesn't work, you've got concrete. And then I said go and see your GP and get 2 litres of saline every week for 6 weeks and come back and see me. And the saline is enough to rehydrate the motion, soften it up, and to allow the precalopride to work. And I have some patients, I've got about 10 patients with POTS that have PICC lines, Hickmans or ports to net 2 to 3 litres of saline a day just to be able to stand up and function. But there is this reluctance, just drink it, so they can't drink it. And so aggressively addressing the fecal loading. So the most common cause of gastroparesis and inability to eat and needing a nasogastric or a nasojejunal feeding is your colon is chock full of poo. So rather than not give you fluids and stick a tube down your nose and then feed you with a poisonous feed that the Nestle's made, we rehydrate your faeces, move it out, and your gut starts working, you can eat what you want. So they're the basic principles. So in summary, the gut-brain axis, dysfunction in one area leads to dysfunction in all areas. The concept of stress as being physiological, not just psychological. Your clinical manifestations of disease when your gut-brain axis is dysfunctional will depend on your genetic predisposition and the stress or the triggers. Improvement in one area will always lead to improvement in all areas, and don't overlook the low-hanging fruit, which is fecal loading, salt and water, and diet and potential allergens. Okay, any questions?
Thank you so much. That was amazing. I've got a page full of notes. So we have got a bit of time for questions, and getting the signal to stand closer, just shoulder to shoulder. I've got a ton of questions too. But what I might do is, I won't go first. Let's go. You go first, honey. You had your hand up. This done? We'll just get the mic.
It's this, one of the things that don't word aerophagia, and I just wanted to speak aerophagia.
Yeah. So no, there is. So when people say they belch a lot, it can be SIBO can actually in the upper intestine can produce excessive gas that will come back up into the stomach and out. But the classic aerophagia is a little, usually it's psychological. It's a subconscious psychological problem where I'll have a little old lady, I've only ever seen it a couple of times and they're older people, and they're sitting in the consultation and you can't see them swallowing the air, but the entire consultation, they just burp through the entire consultation, and they're subconsciously swallowing air. And there are some genetic diseases where they do that as well. And so diaphragmatic breathing is important. So just like rumination. So cows are ruminant animals. They eat, they bring it back up, they chew their cud for further breakdown, and then they swallow it again. So rumination is, again, a subconscious thing where when you eat, for the first 5 to 10 minutes of eating, your diaphragm contracts not properly, and it will come back up. And so the symptoms are, for the first 5 to 10 minutes after eating, there is passive regurgitation. So you're not vomiting, it's just coming up into the back of the throat. It tastes yummy. It tastes like what you just ate. So you can chew it and swallow it, and it tends to gross everybody else out. And so the family members say you need to go and see someone. That's disgusting. You can spit it into a tissue. You can hold it in your mouth. It's not, like if it's projectile across the room, that's not rumination. And it only happens for the first 5 to 10 minutes after eating, because after that there's been sufficient mixing of the gastric contents so that now when it comes up, it's acidic, unpleasant, and the procedure and it'll self-abort. So we recommend after eating for the first 5 to 10 minutes to do diaphragmatic breathing, because you can't contract your diaphragm and regurgitate it. And then there's volume regurgitation, which is where people have delayed gastric emptying for whatever reason, and when they sort of bend over, stuff just comes flying up. And again, that usually gets misdiagnosed as rumination.
I guess I'm thinking about kids with ADHD, and you do a direct strain, you've got a really distended stomach, like really.
Yeah, so I don't see a lot of that in my children. I also worry about if they do swallow air and they've got vascular compressions, or they get gastroptosis and they're staying it in there. But I don't tend to see that in adults as much as that swallowed air.
Thank you. That was an amazing talk. What are your thoughts on sonic hydrotherapy? I'm pretty neutral about it. Maybe I shouldn't be so neutral about it.
Look, before my awakening, I used to think vitamins were expensive and colonic hydrotherapy was a dangerous, silly thing to do, because it's like a garbage bin. The man comes and empties it every week. It empties. Now that I know about fecal loading, I think it is important, because I'm seeing a lot of right-sided fecal loading. So when I don't do colonic transit studies, because if it's slow, well, I knew it was slow. If it's held up here, it's because you're not defecating properly, and I can feel it, and I can get all my patients to see a pelvic floor physio anyway. And if it's stuck on this side, well, I can feel it as well. And it doesn't change my approach to management. So I don't, and then sometimes you do a colonic transit study, it's normal. And the patient stopped all the laxatives, yet they're severely constipated. So I'm finding a lot of right-sided fecal loading, and you can't get that with laxatives. And so I always look at images myself, because X-rays are reported poorly, CTs are reported poorly, and my view on it is that we always get taught X-rays not how you diagnose constipation. It's like, but I'm not diagnosing constipation, I'm diagnosing fecal loading. But generally, if you push on someone's tummy and it's tender, they're walking around the street. They haven't perforated an organ. So what's tender? You're pushing on feces. So when you've got a skinny girl or a skinny patient, I can feel the sigmoid loading, and in the right colon it's just a mass. Whereas if you've got a big tummy, I can't feel anything. But if I push and it hurts, that's poo. And the poo's here, or it can be up here. And so sometimes fecal loading mimics biliary disease because it's stuck up there. But I don't know why it's getting stuck on that side. I think it's a combination of the connective tissue laxity we're seeing post-COVID. So when these patients stand up, they have their right colon attached, and then they have a sharp angulation at the hepatic flexure, and their transverse colon toes into the colon. And I can be at colonoscopy and come to hepatic flexure and not be able to get around. And I can push hard enough to perforate the bowel, and I still can't get around. I roll the patient, it opens up, whoosh, off around I go. So if I can't get around pushing, how does poo get around that tight corner? And you stand upright all day. You don't lay down and eat. So I think that what happens is it gets stuck there because of the angulation. Plus, these patients that have right-sided loading either have a neck injury with loss of lordosis in their neck, or they have a hypermobile EDS or a hypermobile neck, and the anatomical changes compress the vagus in the carotid sheath. And we know the vagus supplies the entire gut and the right colon. It peters out somewhere along the transverse colon. So I think that, and you look at it, the right colon on the CT is this big, and the descending colon's this big because it's been there. And colonic hydrotherapy is necessary to get to that, because when I'm in the colon, I can see the valve here, but the cecum is back here. And so the valve is here, and I'll watch the valve prep come out and come straight this way. So, but then sometimes they've got a really deep cecum, and so it's just coming, like the laxatives are coming straight out this way and not dissolving that big chunk that's there. So I do use colonic irrigation. The problem is it's expensive, because I usually say to patients you need to do it twice a week until no more hard feces comes out. If you're seeing hard chunks and if you're seeing lots of mucus, that means the bowel is lubricating the feces and trying to slide it out. So excessive amounts of mucus in the discharge tells me that you're fecally loaded. Plus you can massage and feel. And you keep going, and sometimes patients will have 6 or 7 irrigations where not much is coming out, and then at the 8th, just because it's been rehydrating the feces each time, and then at the 8th one, all this stuff comes out, and they go, oh my God, there's all these undigested vegetables. I saw broccoli, and I haven't eaten broccoli for 3 months, and I know I haven't eaten broccoli for 3 months because I don't like broccoli. And it's a sign that you're clearing that fecal loading, but you can have, I mean, it's gross to think that you can have undigested masses of food in your colon for months and months at a time. So yes, I do, and some people are exquisitely sensitive to the stretch. So you do need to use very low pressures, because otherwise it'll trigger a vagal response and they can pass out or have severe pain. But I used to do that a lot. The trouble is, it's frowned upon by the medical community, and if something goes wrong, I'm liable for recommending it even though I didn't do the procedure. And now I'm finding IV fluids are much easier, plus it makes their POTS feel better. And if you can't get the fecal loading out, so I'm seeing so many people that are intolerant to laxatives, they're reacting to Movicol and they just react to everything. If I can't get the fecal loading out, then I give up and I turn to the mast cells, because if I stabilise the mast cells, so I have people like some colleagues that will put in, not laxatives, they put in sodium chromoglycate. So I have patients that are severely constipated, they add in sodium chromoglycate and they start going regularly. They're still full of poo, but it's no longer bothering them. And that's because you've settled the mast cells down, you've settled the POTS down. So it doesn't matter which arm you target, but I just target the poo first because it's my area, and then if I don't work all the reacting, then I'll target the mast cells.
Do you stop taking the laxatives once you've cleared the fecal load?
No, because it'll come back again. So you clear it all out, but if you haven't addressed why, which means have you treated your POTS and your MCAS, then no, you need to stay on it until you treat those things and you get below that line. But the trouble is, we're not taught about constipation. We get like one lecture. I've used precalipride once in 20 years until I started managing this area, and it's off you go. I've fixed your problem, off you go. So you've got to fix the problem, and gastroenterologists don't realise or don't believe in POTS and MCAS, and we don't know how to treat severe POTS and MCAS. So the mild people, removing gluten will settle their MCAS down, or just adequate. Like we tell people, exercise increases your vagal tone, drink water, but the water can't stay in your body if it's not balanced by salt. But we've been tricked into thinking salt is evil. And so we tell people not to eat salt. They need to balance the salt and the water, otherwise they just peel the water out. I have people that are drinking 6 litres of water a day and are still thirsty, and so they drop down to 4 litres and add in some salt, and they are not as thirsty. So if you can address the underlying cause, then you can, but I have patients that are so severely unwell that they'll never get off it, whereas a lot of people, if they exercise, do things to your diet and do things to improve their vagal tone. You know, there's so many free things we can do to improve vagal tone, humming, breathing, all of these lovely things that we have at the bathhouse, then that's enough. But if you don't address them, then yes, you have to stay on laxatives forever. I'm fibre. So fibre is good for people with mild functional gut symptoms. The more severe you are, the worse it's going to be, because if you've got a big chunk of fecal loading and then you add in some lovely soluble fibre, which is bacteria food, the bacteria eat it, they produce gas. The gas can't get past the fecal loading because it's blocking the bowel, and it stretches the bowel in the same way that fecal loading does. So I don't introduce fibre, and it's frustrating when I say I'll go and see a pelvic floor physio or a dietitian and they introduce fibre, and it's like, no, I was going to get there, but not right now, and then their gut shuts down. And so I say to patients, if you ever introduce fibre and you get worse, it means you were full of poo. Stop it, increase your laxatives, try again. But rather than taking fibre supplements, it's better to have a diet that's high in fibre, and it's certainly better that it has a diet rather than taking a pill. You know, you want your diet to provide you nutrients. Sometimes that's not always possible, but you want a diet that provides your fibre and your probiotic food and your there's postbiotics as well. So yeah, sorry, long-winded explanation. Okay.
Do you use some of your clients to trigonometry before you send to pelvic physio, or you send that to?
It depends what I'm thinking. So I used to do them because, again, in 20 years I've never ordered anal manometry because rectal disorders are the domain of the surgeons. We don't learn about rectal evacuatory dysfunction. So I did 500 and realised there were 2 normal ones. And so I gave up doing them. There is a fantastic centre in Brisbane called the Queensland Pelvic Floor Centre that bulk bill anal manometry, and the nurse there, Dina, is amazing. She can feel prolapses, rectocils. You know, we weren't even taught to do rectal examinations. We stick our finger up, wobble it around, but they can feel rectocils, prolapses, the tone, what the pelvic floor is doing. But if you've got a good pelvic floor physio, and on their website they have locating a pelvic floor physio by suburb, and they do the whole of Queensland and northern New South Wales, and so they've done their training course. So a good pelvic floor physio should be able to figure that out through examination. So the times I reserve it is more so in my older women who have rectal hypersensitivity. So if I find that I give them osmotic laxatives and they're reacting to Movicol or Osmolax, then I go for more the natural ones like magnesium citrate, magnesium oxide. But if they have severe reactions to it, sometimes it's because they've got rectal hypersensitivity, but I can't pick that from listening to them. So then if I see that on examination, then I'll remove that class of laxatives and try more for the pro-motility or the stimulant laxatives. The only other case I do it for is when people sound like they have a really high internal anal sphincter tone. So you've got the 2 sphincters, you've got the internal and the external, and the internal is under control of your autonomic nervous system, and it can be hypertonic. And so the normal resting pressure is high 30s millimetres of mercury. I have patient 140. So it doesn't matter what she does, she cannot defecate because she can't relax her internal sphincter, and that's not under her control. It's under her autonomic nervous system. And so the classic history in those people is that they get the urge to go, they sit on the toilet, and it takes 30 or 40 minutes for the faeces to come out, but it's liquid. And it's because their sphincter is so tight that only liquid can escape. And these patients, I had one girl and they put her on midodrine because of her POTS. Midodrine contracts your internal anal sphincter. So she went from spending an hour in the toilet, and now with the addition of midodrine, she'd spend an hour in the toilet and she would break out in hives after using her bowels because the increased pressure, mast cells don't like pressure, was activating her mast cells. So every time she went to the toilet, she would be covered in hives. So in that case, Botox helps. And if Botox doesn't help, then you need a loop ileostomy or surgery because we don't know how to relax it. And topical agents, you get tachyphylaxis too, so you get dependent on it, and we don't know how to relax it. Hello.
Thank you so much for that talk. That was like music to my ears. Yeah, I've been practicing for therapy for 16 years and I'm a cat as well. Pardon? So did you hear that?
Yes, yeah. I did.
Oh, you didn't? Oh, it was music to my ears. Yeah. So, yeah, I mean, a lot of those things was amazing to hear.
Oh, thank you. Yeah.
So much about with all of my patients.
Yeah, it's since COVID, it's worse. Like I now, like I said, I used to feel right-sided loading twice a year, and I didn't know what it was. I thought it was a Crohn's inflammatory mass, and it'd disappear after colonoscopy, and I'd say, where did it go? And now every patient has it, and all I can think of is that we know COVID, patients with long COVID get connective tissue and structural distortions in their neck that compress and cause problems with their carotid sheath. And we also know that, I mean, it destroys the nerves, it inflames vagal tone, but then the connective tissue changes. I have patients, there's you can put TENS machines on it. A lot of patients get benefit from whether it's ileocecal massage or it's just pushing the poo around. And I have about 4 patients that see my physio, and they have to drink bowel prep and as well as precalopride to defecate. They have their neck manipulated, and then next day they spontaneously evacuate their bowels, or they will pass 3 days worth of bowel motion from having their neck. And so chiros can do the same, so vagal manipulation in the neck.
Yeah. So yeah, I mean, I've seen amazing results with colonics and the emotional connection.
Oh, it is. I mean, some people, you watch their mood. I had one girl come in and she was so anxious, like it was just coming off her in waves, the anxiety. And she's like, oh, I'm going to the doctor and I'm getting some antidepressants. I said, give me 4 weeks. I gave her bowel prep. That woman that walked in the door again was a completely different woman. She said, I didn't realise it was possible to feel this mentally happy and alert just from bowel prep. Same with dementia. We know that if you trigger POTS, you're going to perfuse your brain and so poorly, and so you get word finding difficulty, memory loss. So I see a lot of older people that have dementia, and they're just full of faeces. And you get the fecal loading out, but if you improve the gut, the brain will improve, but if you improve the brain, the gut will improve. So it's bi-directional. You know, if the psychiatrist manages their mood before they see me, their gut's already improved, but if I improve their gut first, their mood will improve. And there's some people that say, my mood improves every time I use my bowels. The link, when you see it, it's amazing.
So one of the main things that I've read over the years with the gut being the second brain, I just wanted to see if you've heard of it, is that when an embryo is developing as a baby, the brain actually branches off into the large intestine, so that's why the large intestine also has the same house as the brain, so that's why there is such a big
No, I haven't looked into the embryonic. I think it's just, I don't know why it's devolved to develop its own nervous system. I haven't looked into that, but no, I think the enteric nervous system is amazing and designed to work on its own, but it does need those synapses. But no, I've not heard that.
And so can you share what you do with your clients to help them prepare to stop on stools? Like there's a whole protocol before they come.
Yeah, so I mean, I usually recommend to not have any solids in 2 hours prior to coming, just to give the digestive system a rest, also because there's lots of nauseousness and reactions if they have food. But the last few years, I think the last year, most of my patients are so constipated and
It's COVID.
Bad history.
It's COVID that's doing it.
So these days I have to give them like bicarb soda to soften the stools beforehand, like drinking, bicarb soda 2 hours before coming, or salt water flushes to actually soften.
Yeah, so patients, when you say salt, some people get nauseous from salt, or they eat a salt tablet and they feel sick. So sodium bicarbonate is gentle on the stomach and doesn't make them feel so nauseous. It's just things like Eno and Salvital have got a lot of sugar in them, so you might want to avoid that. But no, the fecal loading is just horrific. Like I get parents to come over and feel their daughter's tummies, and I say, that is all poo. These girls are this big and they're just all full of poo. And then it increases the pressure in the abdomen. They don't breathe properly, and then they don't drain their lymph, and it's just the flow-on effects are just horrific as well.
And then in regards to not using chlorine hydrate, because that is my recommendation, but as you said, it's expensive. When you said that you usually give osmotic laxatives and 2 litres of saline, is that saline IV or is that?
No, IV. So it's a treatment for POTS. So some people again, we're learning. There's different subtypes of POTS, which I believe all subtypes are active in all patients. It's just which is the predominant form. But I've seen people go from hyperadrenergic POTS, so that release adrenaline, their blood pressure rises, they've got high blood pressure despite being thin, they get the feces out and then they pass out every time they stand up because they turn into a hypovolemic POTS. But sorry, what was the question?
Yeah, so the saline IV.
Oh yeah, so I do the osmotic laxatives, then I do the precalpride, and if the precalpride doesn't work, then I add in the IV fluids, and I just give them 2 litres of saline each over an hour each. They tolerate it at that rate. The young, healthy girls with healthy hearts, they just have preload failure. They're not getting blood back to the heart, and it works to treat. Some of them even use their bowels as soon as the fluid goes in. So I'm not sure I don't see how it can get into their bowels that quickly, or whether it's treating the POTS and so they're going into more of a vagal dominated state just from IV fluids, and that's making their bowel work. But some of them say as soon as the fluids go in, half an hour, I have to use their bowels, whereas they use their bowels 3 times a week, and giving them fluids will make them go to the toilet without needing laxatives.
And the osmotic laxatives?
So look, I start with Movicol and Osmolax just because I know they're predictable doses. They can get them from the chemist, but I'm seeing reactions post-COVID that I never saw before, and I think it's the PEG. So I see people that have one Movicol and have explosive diarrhea 20 times, and it's like, no, these are gentle laxatives. They're not party trick laxatives. So, you take one, you have a nice soft motion the next day. I said, so that's a reaction. So then I will go on to the problem with the magnesium citrate and the oxide, and I prefer not to use sulfate just because of the sulfur issues with some of my patients, is that they all come in different sizes. They all come in different forms. Some of them have got other things, and it's very individual. I know what one Movicol should do to a patient, but I haven't quite figured out how much magnesium. And some people are exquisitely sensitive to magnesium, and other people can take 6 tablets and nothing happens. And then no one wants to take 6 horse tablets a day, do they? So it's just a matter of finding something that works. Yeah.
Segues on to my question about vagal nerve stimulation. There's some early studies looking at vagal nerve stimulation for POTS and for MCAS.
I find it in my cohort very disappointing, so I do recommend it. You can get a TENS machine with an tragus attachment, but my view is that my patients are predominantly hypermobile, and I think that they've got compression of their vagus here. So if you're stimulating it at the nerve, it's not getting down. So the TENS machine can cause electrical stimulation, but what we're trying to do is, and we can't easily put a vagal nerve stimulator down lower, but that's where nicotine and ultrasound come in. So nicotine binds to obviously the nicotinic receptors, which are on both arms of the autonomic nervous system. So people think of nicotine as a stimulant, but it depends on the person. And I think POTS is a collection of diseases where you have autoantibodies against all the different autonomic nervous system receptors. So it's just a collection. But we know that the spike protein from either COVID or the vaccine will bind with more affinity to the nicotinic receptor than acetylcholine, so it reduces transmission. So if you use a nicotine patch where it's continuously delivered, it pushes the spike protein off the nicotinic receptor and binds. And so some people can respond to that. So I recommend it usually for brain fog and energy levels. We do it a week on, week off to avoid addiction. Disappointing. I've had maybe 10 people, dramatic responses, life-changing, can help them get out of the house, walk around. Other people, nothing, or they'll get side effects, which are headaches and nightmares. The newest area I'm looking at is there's this really interesting chap on Twitter called Sterling Cooley, and he's been doing vagal nerve. And so you buy an ultrasound machine, which I've just got, and basically you use the ultrasound to stimulate your vagus. So you rub it up and down on your vagus. You can stimulate the spleen, because the reason that nicotine is effective is there's something called the vagal anti-inflammatory reflex. So the vagus goes down through the celiac ganglion, which is unusual because it's a sympathetic ganglion, but it has a vagal, into the spleen. And when you stimulate the vagus, it tells the spleen to reduce inflammation. So if you stimulate that, which is what vagal nerve stimulation is doing, you reduce inflammation. So the vagus is essential for reducing inflammation in your body. And so if you don't have vagal tone, you're going to be inflamed. And so nicotine can do that. But this ultrasound where you directly stimulate the spleen for 2 minutes a day, you can do it on your sacrum to stimulate the parasympathetics that go through the sacrum and can lead to defecation reflexes. People are putting it on their insular cortex for depression and mood, and he got into it because it's the ultrasound does something, I don't understand the pathophysiology, but it helps with Alzheimer's, and so they're using ultrasound for Alzheimer's as well, and that's where his research is.